उनका करना था बट कोई नहीं. Hello to everyone. Good evening, good evening. I'm just waiting for it to start. I hope I'm audible, visible. I hope all have joined in. Please join in. We are starting the session. Good evening, good evening. How are you all? I hope I'm audible, visible, because I'll be starting the session very, very soon. One second, okay? I'm just looking at. Okay. So thank you very much. I hope you all are enjoying. Acha, volume I'll increase, don't worry. I'll increase the volume. And the PDF, again, same thing. I'll make a PDF updated, then I will post it. So I'm just going to increase the audio a bit. 120. So I think now I'm audible, visible. Is the voice clear? So I hope I can be audible here because we'll be starting the session soon and we'll be starting with the pediatrics. Again, I'll be covering almost all important concepts in pediatrics in today's session, and it is going to be, yes, very, very beneficial to all of you, okay? Because already Pankaj Tikku sir has taken a session. I'm just going to make it much faster and much more, rapid to all of you, okay? So rather than starting with this, okay, so we'll start with the jaundice, okay? So I hope all will join. I'll just wait for 2-3 minutes and we'll be doing it here, okay? So just wait for some time, then I will wrap it up, okay? So please join in. Yeah, good evening, good evening. So last time we discussed psychiatry. Before that, I have done physiology also. And our target is we are going to discuss as many topics as possible so that we are having a very good chance of getting a score in the exam. Okay. So today's session is about the pediatrics. We'll cover all CVS, CNS, respiratory parts in the pediatrics. Okay. See, if you feel like forgetting, my advice is look at the notes and try to recall. Don't try to read the notes. When you try to read, your brain will resist and you feel like you don't know anything. So what you do is look at the page, close the notebook and try to recall. Okay, what is the drug of choice? What is the mechanism? What is the investigation? That will you remember and revise very, very well. Okay. Class is 2 hours, maybe 2 hours, 20-30 minutes. So we'll wrap it up in 2 hours. That's our target because we are trying. Okay. Yeah, every student can watch. FMG, IMG, all can watch and they should be able to understand and discuss whatever they are having in this case. So my request is please, please, please watch it and so that we are able to learn and do it properly in this case. Okay. So we'll be starting another 1 or 2 minutes. Okay. Yeah. Thank you. Thank you. Good evening. And offline will be starting from tomorrow. Okay. And tomorrow we'll be discussing the offline session in Delhi Center. So that is the whole story we will be discussing. So yeah, I wait for everyone to join in, then we will discuss and have the class. Yeah, and PDF, yeah, obviously I will be giving the PDF to people. They can use it for their own use. Okay, We are expecting around 8 to 10 MCQs from this pediatric session, so it will be very, very beneficial to all of you. Okay, I've increased the volume already, I think, so it is sufficient. Yeah, thank you. And online session, yeah, obviously online session will occur continuously, and offline are occurring in Gautam Nagar. Okay, yeah, I'm trying my level best to take daily session, and we have given a schedule also. You can check it in the DBMCI Premier group where the schedule is there. Okay, yeah, so energy, I know, agree, but you know, so he's also busy taking his sessions. Okay, and yes, yeah, content is almost same. Content will not be different. Content is almost same, online or offline. Okay, so I think we'll start the session. Okay. Okay, so today first we'll discuss in pediatrics what is the concept of the jaundice. So jaundice, as we all know, is a yellow pigmentation of skin sclera. Okay, and it is due to increase in the bilirubin. So due to bilirubin in adult more than 2 milligram percent, but in newborns more than 5 milligram percent, which is called as the which condition? It is called as the jaundice. Now remember, if patient is having a yellow urine, it is called as choluric jaundice. It is called as choluric jaundice, and it indicates an obstruction of the bile duct. Why? Because if there's an obstruction, it causes an increased conjugated, and conjugated can come in the urine. So that's why it is increased conjugated bilirubin. So bilirubin. Whereas if urine is not yellow, it is called as acholuric, and it is mostly unconjugated. Okay, and if normal urine color, it is acholuric jaundice example, and it is mainly seen in unconjugated bilirubin. Okay, or prehepatic. Fine. So you can use these notes, they are updated and they will help you. Okay, Dr. Sara is here. I hope everything is fine. Okay, so very happy to see Dr. Sara. You see, we are always trying to help as many students as possible. So we want the students, especially the NEET PG preparing students, to also have a very good attempt at their exam, and they should give their level best. Okay. Now fetus. So the funda about the fetus. So fetus has fetal hemoglobin HbF, which is very high affinity for the oxygen. Reason, it has no beta chain. Reason, no beta chain. That's why it doesn't give the oxygen to tissue. So tissue suffer from hypoxia, and that's why fetus has very high hemoglobin count. Now after birth, the fetus need HbA, which is low affinity, and it why? Due to more 2,3 BPG binding. So that is why it is now mandatory to break down the old RBC hemolysis which occur in spleen and the liver macrophages. This releases the hemoglobin, and we get iron and the heme. Okay, tetra pyrrole rings, which is initially biliverdin, which is green, then converted to bilirubin. Okay, this bilirubin is highly lipid soluble, unconjugated. So liver will do conjugation by the enzyme UDP glucuronide, transferase, glucuronide transferase, and this causes the conjugate bilirubin, which can be excreted in the urine. Okay, as urobilin. Okay, as urobilin. Okay, so just remove it. So that causes dark yellow urine. Okay, and normally if it goes to intestine, from intestine it can go to our and excreted as urobilin. Okay, so conjugated can also be excreted, and if it go to intestine, it is then excreted in urine as urobilin. So if it goes, it causes choluric jaundice, or if it goes, it can go as urobilin, which give you dark yellow urine. So if you are getting a dark yellow urine, it is because of conjugated bilirubin in this case. Normally bilirubin is secreted in the bile, it goes to intestine, the bacteria convert it into stercobilin and also urobilin. Only thing, urobilin is urine. Urobilin is when it goes to urine, and stercobilin create the yellow brown color feces. Okay, bacteria. So gut bacteria convert it into what substance? It will convert into Is the volume still low? I don't know why the volume is coming low. I will try to increase the volume. Okay. So I hope now audible, loud and clear. I've increased the volume. So is the volume now more? So is it fine now? Volume. Tell me. If it's loud, then I will check. So I think it's fine now. So we'll continue. So next point is, so there are two kind of jaundice. One is unconjugated or there is conjugated. Conjugated is mostly obstruction. So there's obstruction. This conjugated will go to the urine and cause a very dark yellow. Normally what happens, it goes to urine as our this. Okay, clear? So that is as the concept. Are you clear? Urobilin. Okay. So just modify this diagram a bit. So I'm just trying to add a point. So this is called as choleric jaundice. If it goes to intestine and then goes to kidney, this is causing the urobilin. So it goes to absorb to the blood and then goes to kidneys. So stercobilin goes to liver, liver to blood, and then kidneys make it as urobilin. Okay. Now comes the question. I think it's better now. Okay. Now, bilirubin is basically causing multiple kind of jaundice. Okay, if RBC breakdown in newborn, that is increased bilirubin occur when the unconjugated, and it causes jaundice in the newborn. It is called as physiological jaundice. Okay, and if there is other condition, we can have a pathological jaundice also. Okay, now how do you differentiate physiological from pathological? Follow the rule. Physiological is like a normal wanted guest. Okay, so what happens is a normal wanted guest inform and come. Can I come? You say yeah, you come. So that's why it appear after 24 hours. Okay, where the unwanted guest, Athithi tum kab jaoge wala, he comes same day. So that is same day of the birth. So that's why what appear after 24 hours of the birth is same day of birth. So that is why if it appears same day, it is pathological. If it appear after 24 hours, it is called as yes. So that's why before 24 is pathological. If it appear after, it is called as the yes, physiological condition. Okay. Next condition, a normal guest will stay only for few days. So you can remember like this, a normal guest stay hardly 3-4 days. So if it is over within 7 days, 1 week, it is physiological. If more than 7 days in term, it is pathological. So again, pathological lasts like a unwanted guest, doesn't want to go. So that is increase. Okay. And PDF file upload after the class. Okay. If more than 14 days, it is preterm. So that is why more than 7 day in term and more than 14 day preterm is pathological. Then daily rise is 5 milligram per day. It's physiological. If daily it is rising more than 5, it is pathological. So remember, more than 5 is pathological. Total, it never cross 15. So always less than 15. It crosses more than 15. And in this case, the conjugated can cross this, its books say differently, 2 milligram %. It will always stay less than 2. So I just need to correct it again. So it stay less than 2. Okay, less than 2. Then comes the next question. What is the treatment? If physiological, no need to give any treatment. Why? Because it is going to correct by itself. So it is reassure the patient, everything is fine. No. Here we need the treatment. What treatment? PPP. So triple P. Or the first P, phototherapy. So when you give UV light to the kid, it converts the bilirubin, become lumirubin, which is water. So remember, UV light convert the L. So bilirubin become lumirubin, which is water soluble. So it's excreted in the urine and the jaundice clears, and the jaundice will clear. So that's very, very important in this case. Then plasma exchange transfusion. So if there's very high bilirubin or there's a risk of conjunctivitis, then we can go for what? Plasma exchange transfusion. That is, we clear the plasma and it infused to the patient. Okay. Now, what are the drug? We can use phenobarbital, which is a barbiturate. It's an enzyme inducer. in the liver, activate cytochrome P450, so cause more conjugation and clear this. But remember, it is contraindicated in porphyria. So very important question, where is it contraindicated? Answer is in porphyria, the barbiturates are contraindicated, especially intermittent porphyria. Intermittent. Okay, it is contra. Now in newborns, the blood-brain barrier is partially developed in newborn. So that's why bilirubin can cross it and reach the brain, and it can cause what? It can cause damage, cause seizure, called as connectors. So that's why treatment is essential if it's a pathological or very high level of bilirubin. Why? Because connectors risk is there. So what is the substance? That is one issue is there. So connectors. So bilirubin. Okay. Now comes the question. It's a very important PYQ. One PYQ is, they ask in 2018 NEET ki what is the barbiturates contraindicated in porphyria. In that case, they were asking what is the reason, because it's an enzyme inducer and it causes increased formation of these chains. Okay. Finally, what else is also there? Okay. Thank you. Yeah, it's very beneficial if you do it. It'll cover almost all important concepts in your pediatrics. Okay. Now, next question. What is Kramer rule? Kramer rule is for visual assessment of bilirubin level. So you can just check and see. So I'll use a very simple rule. Face have 5 senses. Face has 5 senses, so 5. Chest, when you give CPR, we use what? 2 hands, so 10 fingers. So chest is 10. Then remember, our shoulder and thighs are 12 to 15. So they are 12 to 15. And palm and sole, remember how many fingers we have? 20 fingers. So we have 20 fingers in palm and sole. 20 fingers. So 20 mg/% is palm and sole. So palm and soles is 20. So palm and sole is which value? It is our 20. So very simple rule. Face, if you see yellowness, it is 5. If you see in the chest area, it's mainly 10. If you see in shoulder, it is 10 to 15. You can say 12. And if it occur in this, it can be up to 15. So that means as you're going away, the bilirubin level is higher. Why? Because face you can see even at 5. But for the palm and sole to be showing the jaundice, it should be 20 or above. So finger, that is palm and sole is 20 mg/%. So that is called as the Kramer's rule. So it's called as the Kramer's rule. Let's see the Kramer scale. So they are giving this. Face is 4 to 6, that is approximately 5. Chest and upper is 10, which I told you already. Lower abdomen thigh is 12 to 14, which I told. Lower legs and arms, this part, it will be 15. And if it reaches palm and sole, 20. Remember, 20. This is called as the Kramer's rule in this case. So Kramer's rule. Okay. Now, one more interesting thing that we will see or discuss or have is, there are 2 types of jaundice that you need to remember. I'll write it here. So that is conjugated and unconjugated. So I'll write it down and we will use it. Okay. So which one is, and also we are having physiological jaundice, which I discussed, breast milk jaundice. So it causes what? It's because of what? See, increased absorption of bilirubin from intestine, but main is what? The fat in the breast can displace the bilirubin from the plasma protein and can cause increase in the jaundice because of increased unconjugated bilirubin. Now remember, there is a mnemonic, that is you can go to see doctor. See. So mnemonic is you can go to see doctor. So you means unconjugated is seen in go. It is seen in, so you can. So that's why unconjugated is seen in Krigler Nazar. Krigler Nazar 1G. So Krigler Nazar syndrome, where there is a defect in conjugation, and also G for Gilbert. So Krigler Nazar and Gilbert show which condition? It show unconjugated. Defect is in conjugation. So there is a defect in conjugation. And in CR, that is conjugated, is seen in DNR, that is Dublin-Johnson. And R is rotor. So rotor and dublin, there is a problem in secretion or the transport, that's why it's causing conjugated one. Okay, so you can see I'm actually very tired because I'm taking class since morning and then I prepare my slides for your chantings plus offline session. So very tired in this case. So don't worry, I'm okay, fine. Chalo, let's move on, let's discuss. Okay, so what is the mnemonic? You can see, you can go to see doctor. So you can, you is unconjugated, is Krigler, Nazar and Gilbert. GG. So remember GG, GG, mnemonic is GG, GG. क्रिगलर गिलबर्ट दोनों आपके अनकॉन्जुगेटेड. जीजी इज अनकॉन्जुगेटेड. ओके, whereas DR dublin and rotor are your conjugated, they are your. And remember rotor motor, there is a problem in the movement of the conjugated bilirubin. Okay, fine. So PDF I will upload, Palak, don't worry, it's already in the Telegram group and I will give it to you. You can just message me. Okay, so I just give my number, so you can message me at this number. I will send the PDF after class. Okay, 9899 529 468. So this is our number. Okay, most welcome, Divya. Okay, so this is our funda about the topic. Okay, now let's come back. Okay, now we will discuss the next topic. So summary, what is the summary? How do you know physiological or pathological? Very simple. If same day, it is pathological. After one day, it is pathological. If daily rise more than 5, pathological. Last more than 7 day in term and 14 day in preterm, it is your again pathological. Okay. Treatment, if pathological, we do PPP. P for phototherapy, plasma exchange and enzyme inducer, phenobarbital. Risk is your conductors. Okay. That's the important thing we will have. Okay. Fine. Kramer rule is face is 5, chest is 10, then shoulder etc 12, then arms it can be 15 and palm and sole is 20. Remember face is 5, chest is 10, palm and sole 20, rest is 15. Next is we discuss our dehydration. Now that is obviously a decrease in the ECF. So exam question, what is diarrhea? It is decrease extracellular volume and it's a loss of isotonic fluid. Yes. First question, most common cause is diarrhea, in which also we have rotavirus, and for that we have a oral vaccine at 6, 10, 14. 6, 10, 14. Okay. Now bacterial they are asking E. coli, mainly gram negative. Mostly they are gram negative plus salmonella typhi. So this typhoid, not thyroid, by mistake typhoid. So typhoid, just correct it. So it is typhoid. Then so typhoid, Vidal positive. Then Shigella. Also we are having cholera. So they all are causes of dehydration. Now if there is mild to moderate dehydration, the best is child is thirsty. If they mention child is thirsty, we will always suspect what? We will suspect it's a mild to moderate. Are you clear? And in this case, we need to give what? We need to give ORS. Okay, so the treatment is we give ORS. How much? 75 ml per kg. Like example, if a child is 10 kg, we need to give 750 ml of ORS. Now ORS has sodium equal to glucose. Okay, why? Reason, they have same osmolality. So the osmolality is same, 75. Okay, and why? Because they are co-transported with the help of your SGLT1, sodium glucose linked transport. I will cover milestone also, don't worry. Okay, Palak, I will cover each and everything. Okay, now what is the composition of this? So composition is, it contains 75 milliosmol of CC. So what is CC? Chloride is 65 and citrate is 10, total 75. So remember 75 total 2. So remember 75 is sodium, 75 is glucose and 75 is chloride plus citrate, total 75. That's what I say. Okay, and potassium is 20 milliosmol per liter, total is 245. 245 milliosmol per liter. Now there is also something called super ORS, not superoxide, So what is super ORS? Let me explain. So super ORS. What do you mean by super ORS? Okay, here it contains less sugar but extra amino acid. Why? Because when you add amino acid, it will cause an increase in the sodium reabsorption with the help of sodium amino acids import. So that's why it become what? It become a super ORS. So what is it? Super ORS in this particular case. Okay. Now, severe dehydration. What is the rule here? In severe, the rule is child is not thirsty, not responding, maybe unconscious, drowsy. So one thing is not accepting. If a child is accepting the fluid, it is mild to moderate, we can give ORS. But if the child is severely dehydrated, he is not going to accept the fluid. Other finding: sunken eyeball, fontanelle, dry eyes, mouth, no tear, saliva, decrease urine output, and skin pinch retract very slowly. So that is the hallmark of which condition? Of our severe, plus also decreased turgor pressure. So the decrease in the skin turgor pressure. Okay. So if there's a decrease in turgor pressure, the skin pinch retract very slowly. What is the diagnosis in this case? So what is the diagnosis? It is your severe. Treatment is IV ringer lactate. So RL is the treatment for severe dehydration. How much is the dose? We'll give 100 ml per kg. So remember, if it is ORS, we need to give 75. ORS 75. And remember the rule, 75 rule. So ORS, what is the rule? 75. What is the amount? So I'll just teach you. So what is the rule of ORS? 75 rule. What's 75? 75 ml per minute. 75, sorry, ml per kg is the dose. Then ORS, what is the composition? Also 75. 75, 75, 75. 75 sodium, 75 is the glucose, and 75 is chloride plus citrate. It is 65, it is 10 total, plus 20 potassium. So this is the 75 rule we have for the ORS. So 75 is the rule for the ORS. Clear? 75. Next question. So are you clear? So 75 is the rule. Okay. Now we will see what the dose of RL. So RL is given IV 100 ml per kg. Okay. So 100 ml per kg. So clear? So 100 ml per kg. Now comes the question, what is the way? So first remember, we have to give it in two divisions. If it is, right, 30%, 70%. So what is the division? 30, 70. And what is the age? Less than 1 year, that is infant, or more than 1 year. If it is very young, you have to give slow. So we'll give it what? 1 hour and 5 hours. Total 6 hours. And if it is 30% correction and this. If it is elderly child, we can give fast, half an hour and 2.5 hours. Total 3 hours. So that is a very important summary. We have to remember 1 hour and 5 hours. Total 6 hours for less than 1 year infant. And if it is, yes, 2 years, then the case. So let me give a question. Question is, there is a 6-month baby. So 6 months. And the weight is 4 kg. Weight is 4 kg. So what will end? Unconscious. So obviously, if unconscious, it's a severe dehydration. We will give RL. How much dose? So they'll ask the dose in part. So what is the answer? Solve the question. 6-month-old, weight is 4 kg. Weight is 4 kg. What is the weight? 4 kg. Severe. So can you tell me how much would be the dose? Tell me how much would be the dose? Thank you, Dr. Prashad. Yes. So obviously, if 4, So 4 into 100 will be, okay, so 100 ml per kg. So you'll be giving around 400 ml. Okay, so what the amount will give? 4 into kg. So 400 ml you have to give. Then divisions, 2 divisions, that is 30%. So 30% will be 3 to 4, 120 and 280. So 120 ml and 280 ml. 120 ml will give in 1 hour and then we'll give it in 5 hours. So this is an exam question that can be asked. So that is 120 ml in first hour is the answer of this question. Very good, Neeraj, Rakesh, Sheetal and Bhavna. Very good. Okay. Yes, VM, VJ. Very, very good. Okay. So that is the right answer in this case. Okay. So are you clear? Now let's come back. Also we can give antibiotic like doxycycline is the drug of choice in cholera. Okay, tetracyclines. Plus typhoid we can use thiazide and cephalosporin like ceftriaxone, okay, or oral cefixime. And zinc is given to the child if less than 5 years. Remember dose, if it is less than 6 months, the dose goes 10 mg per day. If more than 6 months, then 20 mg per day. Zinc deficiency causes a disease called as acrodermatitis enteropathica. Okay. Now fetal circulation, I will make it easy for you. Remember it in my way. You will not ever forget. So I'm discussing what? Fetal circulation in the case. So let me start. So remember for fetal circulation, we all know oxygen from placenta. So where is the oxygen coming from? Placenta via umbilical vessels. Via umbilical vessels. Now there are two, artery and vein. Now remember, artery is obviously going to the placenta, vein is coming from the placenta. So that's why vein carry oxy. It's actually mixed oxy and artery is deoxy. Just like in lung, pulmonary artery carry the deoxy and vein carry the oxygenated blood. So what is the case? Now to increase the flow, we need one vein, because if there are two veins, it will occlude. So that is why what happens? So there are two arteries and two veins. So out of two, only one is left. So are you clear? Okay. So two veins. Now the two veins, one. So remember, left is left. Left is left. And a mnemonic I made is love. Love. Mother give love. So remember, mama give love. Mnemonic, mama give love. So who give love to the baby? The mama give the love. What is love? Left umbilical vein. So it is the one which is bringing oxygen to the fetal side. Now obviously this love is going to give the oxygenated blood to the heart via vena cava. So love is going to shunt the blood to the IVC. How? Via ductus venosus. Ductus venosus, that is DV. So that's why DV is between two veins, vena cava and this. Now from the IVC, the blood reaches the right atria. Now problem, right atria has the oxy blood. It cannot keep it, it has to give it to the left atria. So it give it to the left atria. This is called as your FO. That is what? Foramina ovale. So foramen ovale will give it from right to the left. So that's why oxygen reach, oxy blood reach. Then right atria give to right ventricle. Right ventricle again has to give to the left ventricle. This is called as how? I'll discuss. How? The right ventricle cannot give to lung. Why? Because the lungs are collapsed. So that's why whatever blood they give to the pulmonary artery, oxy blood. Lungs are collapsed, so less is there. So lungs collapse, high resistance. So that's why this blood will again go to the aorta. This is aorta. This is called as DA, ductus arteriosus. So therefore, total, how many connections are there? There are total 3 connections. What are the 3 connections? So remember them. It is ductus venosus, foramina ovale, and ductus arteriosus. Ductus arteriosus. Okay. So DVFODA. 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 Okay. So don't forget DVFO and DA. DVFO and DA. Now comes the question. Question is, after birth, as the lung inflate, the pulmonary resistance decreases and now the blood flow increases to the lung, and lung add oxygen, and the entry of oxygen causes the physiological closure via prostaglandins. So that's why after birth, DVFODA, DVFODA, they have a physiological closure due to prostaglandins. Okay, due to prostaglandins. Anatomical closure occur after few days to months. Okay, so that is physiological closure. Okay, and remember what they are called as. From D they become L. So FO remain FO. That is, it becomes fossa ovalis. But these become L's. D become L. Like ductus venosum become ligamentum venosum, and ductus arteriosum become ligament arteriosum. So that is one line summary we have to remember always and always. So are you clear? So this is the one line summary we should always see. So ductus venosus is DV, ductus arteriosus is DA. Okay, and love. Who give love to the entire world? Mother Teresa. So remember, Mother Teresa give love to entire world. So love become Teresa. So love become Teresa. Ligamentum teres. So it become ligamentum teres. So remember this. So first say after the birth, the DV become ligamentum. So ductus become ligament. D ka L. So D become L. Driving license. Remember driving. So D become L. So ductus venosus become ligamentum venosum. Ductus arteriosum become ligamentum arteriosum. And love. Who give love? Mother Teresa give. Nandini, I am going to discuss that after that. Don't worry. So that is causing this. Okay. So love. So Mother Teresa give the love. So that's why love. Left umbilical vein become ligamentum teres, and arteries become the medial umbilical ligament. So I'll just show you in file. My handwriting is bad, so this I've discussed already. So that's why vena cava is giving the oxy blood from the umbilical veins to the right atria. Then via foramina ovale it goes to the left atria. Then ductus arteriosus give from the pulmonary artery to the aorta, and entire body get the oxygen. So these are the structures. Now after birth, as the lung inflate, the structures will collapse, and that is because of prosta. So PGE2 is the one which close ductus. So very important, E2, PGE2. So fetus, FEF. Remember EF. So now E2 is there. So fetus, EF. Fetus, EF. Now what is the physiological closure at birth? But anatomical occur at 6 to 12 for foramina ovale, and ductus arteriosus is some days, 10 to 12 days. So 10 to 12 days. Now what is the name? FO foramina ovale becomes fossa ovalis after the closure. Then what is the other concept after the closure? After closure, then next point, DA become ligamentum arteriosum, DV become and this, what is this? This D12, mnemonic is D12. D's become L, D's become L, D's become L, and love. Ligamentum teres is becoming Mother Teresa, that is ligamentum teres, and umbilical artery become medial umbilical, yes, ligament, medial umbilical ligament, not ligamentum. So I think I have explained and summarized the cycle very easily. So now you will not forget for the exam. It is a easy, simple summary. So I hope it's clear. So that is the case, ligament. Now, congenital heart disease. So first question is congenital heart disease. There are basically NADA's criteria. So I'll discuss that also. So what is the NADA's criteria? So this is the NADA. I'll rather open it in other file. One second. So I'm just showing you the NADA's criteria. This pediatrics. Okay. So We'll discuss that. Okay, so the circulation I've discussed already. So this is the circulation we are having. Okay, so discuss already, so no need to discuss it. Is ductus venosus, this one ductus venosus, and this is foramina ovale, and this is your ductus arteriosus. Okay, ductus arteriosus. Okay, now this is our congenital heart. So nadas करें, याद करना nada, nada. Okay, so बच्चा नादान बच्चा nada, nada. So kids, very young kids. Okay, नादान बच्चा nadas करें. Okay, so major is basically any systolic murmur grade 3 or more. Diastolic murmur is always pathological. So diastolic murmur, cyanosis or congestive heart failure. They are basically major criteria. Minor is any abnormality in sound, ECG, X-ray, BP or systolic grade 2 murmurs. Okay, so let's revise it very fast. So what are the murmurs we are having? So nada, what are the major? What are the 4 major? So major is which murmur? Systolic murmur more than what intensity? So if there is a systolic murmur more than what intensity? More than 3, grade 3, or there is congestive heart failure or cyanosis or diastolic murmur. So these are the major ones. So these are the major ones that we are having or we are seeing. So these are which criteria? Major criteria. Are you clear? So are you clear? So that is the major criteria. Now comes the question, what are the other important changes? Okay. Now there are 2 type of congenital heart disease, cyanotic or acyanotic. Now remember a very simple rule, I'll give it, then you can always follow. Okay. So congenital heart disease, HD, 2 criteria, cyanotic and acyanotic. Remember first rule, in cyanotic obviously there is cyanosis. Why? Mostly there is, what is the reason? There is either less blood is going to the lung or less coming from the lung. So what happens? Less blood going to lungs or coming from the lungs. So that is the pathology. Clear? I'll discuss everything. Okay, don't worry. Okay. So now comes the question. Okay. Yeah, it is 3 or more, equal to 3 or more. Okay. Now the concept is right on less. So what is the shunt here? So shunt is right to left shunt. If there's a right to left shunt, the blood from the right ventricle goes to the left and bypass the lungs. So what happens? So right ventricle give to left ventricle and bypass lungs. So that is why cyanosis occur. In acyanotic, the blood is going less to the body, but it is going to the lungs. So there is rather, yes, lungs are able to add oxygen, and that's why there is no cyanosis. Shunts are basically right to left shunts. So that's why the blood will keep going to the lungs. So what happens? So left ventricle give to the what? Lungs, and lungs will, so left ventricle give to right ventricle and right ventricle give to lungs. So more oxygen enter the blood, more oxygen in blood. So that's why the blood is oxygen rich. MCQ. So that's why the blood is oxygen rich in this particular case. Are you clear? So oxygen rich. That is the acyanotic. Now what are the mnemonic to remember? Cyanotic are basically 5 T's. They are basically 5 T's and 2 E's. So that is the mnemonic I will make for you. So remember, acyanotics are 3 D's and they are 5 T plus 2 E's. Plus 2E. So what are the 3 D's? They are ASD, VSD and PDA. So ASD, VSD and PDA. They are which disease? They are our acyanotic diseases. So ASD, VSD and PDA. Whereas cyanotic are 5 T's and 2 E's. So don't ever forget ASD, VSD, PDA. Then there are cyanotic, 5T and 2E. Okay. Now how to differentiate? I'll tell in details, but right now one very simple. If they say ASD, the hallmark is it has either no murmur, or it has a mid murmur or mid murmurs, mid systolic or mid diastolic murmurs. But the hallmark is wide fixed split, wide fixed split. That's the hallmark. So wide fixed split. So if a child is acyanotic and there is no murmur or the murmur is mid, the moment they say mid murmur, it is your ASD. Now if it's a VSD, in VSD, remember the technique to recall and solve is, in VSD first, it is a pan-systolic murmur, pan-systolic, PSM, and there's the variable split, variable split. So pan-systolic and variable is VSD, VV, variable VSD. And in PDA, there is a continuous murmur. There is a continuous murmur. So I think it will just solve your question. So if a patient comes with congenital heart disease, there is no cyanosis and there is first mid murmurs, go with ASD. So what is the hallmark? If they say mid murmur, mid and fixed split, wide fix, we will go with ASD. We will go with ASD. If it is pan-systolic, PSM and variable split, then it is VSD. And finally, if continuous murmur, it is PDA. So this will solve most of the acyanotic murmurs. Okay. So fixed split is ASD, variable is VSD, and continuous murmur machinery is PDA. So one line solve the questions. Okay. Machinery. It's a continuous machinery murmur. Okay. Now what are the findings? Remember all these three, the shunt is left to right. So if there is a left to right shunt, it causes increased pulmonary blood flow and can cause what? Pulmonary congestion, loud P2, and also can cause enlargement of the right side, right ventricular hypertrophy. So it causes increased pulmonary pressure and findings. Okay. So let me show you, and this we'll do in diagram form. So let's start now. So first we'll start with the ASD. So in ASD, most common type is ostium secundum, not primum. But if it is Down syndrome, then it is most likely ostium primum. So remember, down is primum, down primum. But if it is asking most common type is ostium secundum. So ostium secundum. Okay. Nandini, I'll tell it. Don't worry. Okay. All this thing I'll discuss. TA, PVC, everything. Okay. Now, what happens? Right and left are connected. Since the pressure is less, silent murmur has less pressure between right and left atria. So that's why mostly it is silent. But what happens? The blood enter more to the right atria, cause more filling. The filling causes mid-diastolic murmur, MDM. That is mid-diastolic murmur. And as there is more blood, it ejects more, so it causes mid-systolic murmur. That's why I told you it's mid-murmur. Mid-systolic murmur. Then what happens is, since there is a longer time for ventricle to eject the blood, okay, why? Because containing more blood. So pulmonary valve close later. So that causes splitting, wide fixed split. So S2 is split, A2 gap, P2 reason. Pulmonary side, the right side is taking long time to eject the blood and then close the pulmonary valve. So it causes a wide flix S2. MCQ. Then since more is ejected to the lung, it can cause pulmonary congestion, pulmonary hypertension, which cause loud P2, right ventricular hypertrophy, pulmonary congestion, edema, which can cause dyspnea, orthopnea, all. Investigation, we can do X-ray, echo. Okay. Now, most of the ASD are asymptomatic, so don't need to give any treatment. Only in severe ASD with some heart failure, pulmonary edema, RVH, we might need the repair of the shunt. So we need to repair the shunt. Okay. Now, the most common congenital heart disease overall is our VSD, and obviously it's the most common. Which one? acyanotic also. So more common overall. If they're asking cyanotic, then it is tough, tetralogy of palate. Okay. Now the most common type is perimembranous, and there is the left to right shunt. It is very similar to ASD. What? Pulmonary congestion, edema, right ventricular hypertrophy. So it's very similar. That's why sometimes what happens? It can cause a reversal of the shunt. So what can cause? So this RVH can cause reversal of the shunt. And if the shunt reverse, it will become what? It will become right to left. And I told you it will become cyanotic. It will be cyanotic. This is called as Eisenmenger phenomenon. So it's called as Eisenmenger phenomenon. So the name is Eisenmenger, which I'll discuss very soon. So reversal of shunt in a long-standing VSD is called as Eisenmenger phenomenon. Okay. Now, in systole, the blood is going from the right ventricle to left. No, it's going from left to right. So that's why murmur will appear in whole of the systole, called as pan-systolic murmur. Why no murmur in diastole? In diastole, both ventricles are relaxing. They have very low pressure. That's why it causes a systolic murmur, but not a diastolic. In diastole, ventricles have low pressure. No shunt is there. No or less shunt and murmur, and no murmur in diastole, as LV and RV have low pressures. LV and RV have low pressures, almost zero. So that is why what is happening? They're having very low pressure in this case, very low pressure. Okay. Now obviously we can do echo, and 90% heal spontaneously, 90% will need a repair. Now in the case of PDA, there's patent ductus arteriosus. Obviously aorta is connected to pulmonary artery via the ductus arteriosus. So obviously blood will go in systole and diastole both. So shunt will be appearing. So features are very similar to the this VSD, etc. Very similar to VSD. And what happens? The blood will flow in both. So that's why murmur never stop, as blood goes left to right in both systole and diastole. In both systole and diastole. Okay. So are you clear? Now that's why it causes which murmur? Continuous murmur. Why? Because murmur never stops. So it occurs in both. Now treatment, if symptomatic repair, or if they ask drug of choice, it is NSAIDs. What the NSAIDs do? It will close the PDA. Now there's a controversy, ibuprofen. So now ibuprofen is slightly superior to indomethacin. So some book have given indomethacin the drug of choice, but some book, but as our Pankaj Tikku sir, so Pankaj Tikku sir said ibuprofen is the superior to the concept. Okay, so it is a case. So ibuprofen is superior to indomethacin. Now what is the summary? Summary is, in cases of acyanotic condition, ASD is silent murmur or can be mid murmurs. VSD is pansystolic, it is most common disorder, and PDA is continuous. Plus it has what? Variable split. It has a fixed split. Fixed split. Okay. Now we have a look at the NADA, so I discussed already. So NADA's criteria is cyanosis, yes, heart failure, diastolic murmur, or grade 2 or more systolic murmur is your criteria. 2 major, 1 minor, or so 2 major or 1 major plus 2 minor is called as what? NADA's criteria. So it is the NADA's criteria. Now, if there is cyanotic heart disease, okay, not at birth, tetralogy of Fallot is the most common. But if they say at birth, it is TGA. So if it is cyanosis at birth or within a week, it is TGA. So remember, TGA is at birth or within a week. And if it is not at birth, they are giving and asking most common. So that's why it is TOF. So TOF is most common cyanotic heart disease. But if they mention at birth, you should go for TGA as the best answer. Okay. Now, we are discussing TOF findings. So TOF. So TOF has 4 features. First is pulmonary stenosis. that causes less blood flow to the lung, and that causes the cyanosis. Then because there is less blood going to the lungs, the right ventricle show hypertrophy, plus there is a ventricular septal defect. So the blood from right ventricle goes to left. Why? Because there is a high pressure in the left side because of pulmonary stenosis and the right ventricular hypertrophy. It shunt blood from right side to the left side, and as the blood go from right to the left side, it causes what? It causes, yes, reduced blood flow to the lung, and that causes cyanosis. So that is the reason of cyanosis. So cyanosis is because of two reasons. One is pulmonary stenosis, and second is because of what? High pressure and the VSD shunting blood from right side to left, so less blood goes to lung. So both causes reduced pulmonary, plus there is a overriding of aorta. So overriding. So the four feature, let's revise. Four features are first, it is pulmonary stenosis, then there is right ventricular hypertrophy, then there is VSD, overriding of aorta. If ASD also occur, it is called as pentad. So if there is a ASD, it is called as the pentad. But if it is having only the feature of right side, not the left, it is trilogy. Like example, pulmonary stenosis, which cause right ventricular hypertrophy, and also ASD, left is not involved. That is no VSD and aorta overriding. So if there is no VSD and no aorta overriding, what is it called as? It is called as trilogy. Okay. Now, what is the clinical picture? Obviously, whenever there is the increased oxygen demand, it produces cyanosis. So cyanosis is not 24/7. Cyanosis appear whenever there is a increase in the demand. That is called as cyanotic spells or TET spell. Okay. And that's why solution is what? We need to make the child sit in a squatting or knee chest, or what is the mechanism? When a child sit in the knee chest, it will compress the vessels of the body. As the vessels get compressed, there's an increase in systemic resistance. Systemic resistance, high resistance will cause what? High resistance systemic will cause what? Increase in the left ventricular pressure. As the pressure is left, it will reverse the shunt, and now the shunt goes from left side to the right side. So now it causes reversal of flow, left to right. And I told you left to right means what? Lungs will get more blood. So that means right ventricle get more blood, pulmonary blood flow increase, more oxygen exchange, correct cyanosis. So the solution, increase systemic resistance to reverse the shunt. That can be done by two things. Either we can give vasoconstrictors or ask the child to do squatting position. As you squat, it increases the systemic resistance. Or what you can do is, if a newborn, you can do knee chest position. So you can take the knees and attach towards the chest. That is called the knee chest position. So what will the knee chest position do? It will lead to a, yes, reversal of the shunt from right to left. From right to left, you make it left to right. That is called as the what condition? Yes, it is called as the reversal. Now, what are the drugs we can give? If there's a congestive heart failure, we can use digoxin for correction of the flow. If you want to improve the, you can say, blood flow, we can do vasoconstriction by giving phenylephrine or beta blocker. So we will do alpha 1 agonist. They will cause vaso, and also morphine is done for pulmonary flow. Now, finally, if severe sign symptom, surgery is the last resort. What is the last resort? Surgery. What do you do? Pot, shunt, and Blalock tossing repair. Okay, Blalock tossing. Blalock tossing. So how to remember? This child is squatting in a potty position, and child is also called as balak in Hindi. Balak. So balak potty. Balak potty squat. And this is the mnemonic we can remember. Balak potty pot. He is who pot, and this. Now what are the X-ray show? Boot shape heart. So boot shape heart. So how to remember? If you see tetralogy of Fallot, you reverse. Top, reverse become foot. Foot is foot. And what do you wear in the foot? Boot. So that's what it's called as choir and sabot. So what is the name? It's choir and sabot. That is boot shape heart. So this is the heart in tetralogy of Fallot. You can see it look like a boot. What is the main reason? Main reason is because of right ventricular hypertrophy. They ask what is the reason of boot shape? RVH, right ventricular enlargement or hypertrophy is the primary cause. So let's revise and summarize. So first, you tell me, okay, I'll ask you, what is the main problem? Main problem is less pulmonary blood flow. Less pulmonary flow. So what do? Reverse the shunt. So reverse shunt. How? By increase systemic resistance. Two method, either we give vasoconstrictors or we can do squatting or knee chest. Now vasoconstrictor we can do is alpha 1 phenylephrine or beta blocker. Fine. So that is the concept, beta blockers we can do. And what is the heart look like in X-ray? I told you squat. How do you squat? You squat to wear your shoe. So that's why X-ray give boot shape heart. Boot foot. Okay. And what is the surgical? I told you it is Blalock, pot or Blalock. So pot and Blalock are the repair. MCQ. So pot, and in this case you create extra connection which increase the oxygenation of the blood in the aorta. Okay. So I hope it's clear. So yes, Coir and Sabot. Yes, you are right, Aditya Shankar. It is the right answer in this case. Okay. Okay, now we will see TGA. What is TGA? So TGA is basically, yes, it's transposition of great arteries. What is TGA? Of great arteries. So what happens? Aorta and pulmonary artery get swapped. So that's why what happened, the blood which is in the lung cannot reach the body and vice versa. So that's why you are separating the circulation. So let me explain this in, look at my diagram, you'll understand. So we all know this is lungs, this is body, this is left ventricle, and this is right ventricle. I'll do it like this. So understand, normally left ventricle give to the body, body give to right, right to the lung, lung give to body. So that is normal circulation. So it is the normal circulation. This is our aorta and this is pulmonary artery. Now what happens in this case? In this case, this connection is destroyed. This connection and this connection also destroyed. So now what happens is the lungs are connected to what? Lungs are connected to the left ventricle via what structure? Via pulmonary artery. So now left ventricle give blood to lungs and oxy blood come to the left ventricle via the left atria. So that means the blood keep rotating in the lungs. So lungs keep giving blood to the left ventricle pump it to the lung. So that means they are giving blood to each other. On the other hand, what is also happening? The right ventricle and the body get connected via pulmonary artery or aorta, via aorta. So what's happening? Body give blood to right ventricle into body via aorta. So that's why deoxy blood is in the body. So that's why deoxy blood keep rotating in the body and oxy blood keep going to the lung. This is called as transposition of gray. So that is why the child will have, yes, the cyanosis at birth. So there is cyanosis at birth. So what is the concept? We will see cyanosis present at which area? At the birth. Okay. Now what is the only thing which can save the baby? If this baby is able to send the blood from the pulmonary artery to aorta, that is via PDA, the baby will get the oxygen and can survive. So that's why PDA is there, baby will survive. So that's why PDA give oxygen to, yes, to body via aorta and body. So that's why the survival depends on what? It depends on the presence of which condition? Yes, so it depends on the presence of patent ductus arteriosus. So that is why we want to keep the patent ductus arteriosus open, and that's why we give drugs to prevent prostaglandins from shutting down. So drug of choice to prevent this closure is alprostadil. So what will keep the dil of the child, heart of the child open? Alprostadil. So that is why to keep it open, alprostadil. So treatment is alprostadil. What it does? Keep PDA open. Yeah, keep DA open. That is PDA or open. Are you clear? So keep patent ductus artery. Yes, it's a PGE2 inhibitor which I discussed in the beginning itself. Okay, so let's come and see the concept. So the oxygen can't go to body from the lung. That's why cyanosis since birth. And if PDA baby survive, we give L-prostadil, which is again PGE2. Yes, it will block that and prevent the closure. X-ray we see egg, GGG. So remember mnemonic G, GG, egg, this string, egg, string, TG, GGG. Okay. Treatment we obviously can do a Jatin switch, or we can do a atrial septostomy to let the blood mix up. For the purpose, you want to make the blood mix. Make blood mix and allow oxygen to shift. Make blood mix. So that is called as the atrial septostomy. Atrial septostomy is the case. Are you clear? So atrial, yeah, anda. Bilkul sahi keh rahe ho, Ankit. It is anda, egg. Now come TAPVC or TAPVR. What is that? It's a total anomalous pulmonary venous run. What happens? The oxy blood from the lungs, which is given by pulmonary vein, it doesn't go to the left side, rather drain more to the right atria. So less oxygen on the left side and more oxy blood on the right side, and that is why cyanosis occur. Here there is a what? Yes, increased blood flow to the lungs. Why? Because blood is going to the right ventricle give to the lung. So that's why body is getting less oxygen, lungs are getting more. So the question asks, is the lung getting more blood? Yes. In tetralogy of palate, there was less blood going to the lung. Here more blood goes to the lung. That's why increased oxygen level in the heart. This question. So that's why increased blood flow to lungs. Okay. So the PYQ, which condition increased blood flow to lungs? In TAPVC. Now types are supracardiac, infracardiac and cardiac. So that is above the heart, below the heart or in the heart. Okay. And if it is supracardiac, it is basically via the vertical veins which make the blood shift from, yes, from the pulmonary veins to the right atria. Okay. And what is the most common? It is abnormal pulmonary vein which drain into superior vena cava and then right atria. That is called as the most common type. Okay. Now what is the appearance? Can you see this white mass? This white mass is because of the abnormal venous connection which give it the figure of 8 or snowman heart. So MCQ. So what is snowman or figure of 8? It is our TAPVC or TA. Yes, and all chambers have equal pressure and oxygen level is also equal. So all 4 chambers are in equilibrium. In equilibrium. This was the exam question asked in the NEET PG. So all chambers are in the equilibrium. Okay. Thank you, Ayush. Okay. So understand. Okay. In TAPVC, the venous return from the lung is not going to the left side. It rather shunts or deviates to the left side. So what's happening? If you want to see the diagram, I'll show you. So in this diagram, if I were to say what's happening. Okay. So I'll make a diagram again to show. This is lungs. This is our right ventricle, left ventricle, body. This is normal connection. So now what happens? The lungs are giving the blood not to the left ventricle, but their blood shifts to the this. So this is your abnormal connection, that is TAPVC. So blood will go from lungs to the right ventricle via right atria. And this is the result. There is less blood to the left ventricle. And as there is less blood to the left ventricle, body shows cyanosis. This is TAPVC. Are you clear? And there is obviously supracardiac. So we can see snowman heart. Are you clear? Snowman heart. Treatment is obviously we need to correct it by removing this abnormal connection. So that is the treatment. Okay. Now Tata. So remaining 2 are Tata. T is tricuspid atresia. Tricuspid valve is not opening. So that causes less right ventricular filling, less blood to the lung, just like it's very similar to TOF. Less blood flow to the lungs because of problem in the tricuspid, not in the pulmonary. Problem is not in pulmonary, but in the tricuspid valve. So it's very similar to tricuspid stenosis. Even clinical findings are same. Treatment will be valvuloplasty. Okay. Then finally, Truncus arteriosus is similar to PDA, but there is a reversal of the shunt. There is rather a cyanosis taking place. So it's a cyanosis, PDA with cyanosis. It's a PDA with cyanosis. Okay. Now, Eisenmenger's is reversal of shunt, which is a long-standing VSD with high pressure in the right side, cause reversal of shunt, and now the reversal become right to left, right to left. Now come Epstein anomaly. Remember Einstein. Remember Einstein mother is genius, but in Epstein the mother is bipolar, BP. So in Epstein the mother is absent-minded, bipolar, and she was given lithium. So mother taking lithium. Now this lithium cause Epstein anomaly, box-shaped heart. So the clinical feature, it is box-shaped heart. Hypoplastic right ventricle doesn't develop, and that's why less blood goes to lung, and again it causes cyanosis because of poor blood flow. Plus there is Wolff-Parkinson-White and tricuspid regurgitation, patent foramina ovale, box-shaped heart are the features of Epstein anomaly. So let me make you remember and revise. See, we have covered half of our PDF in just 1 hour, and we'll finish it in 2 hours all the topic. I just need your support in that case. So what are the cyanotic heart diseases? Let's discuss. Which are they? 5 T's and 2 E's. So 5 T's and how many E's? 2 E's are there. So 5T, 2 E's. 5T and 2 E's. So what are the 5 T's? What are the 5 T's? So we'll start now. The 5 T's are as follows. Understand? 5T. So what are the 5T? They are TOF, TGA, TAPVC. TA, thank you, Rocky bhai, KGF wale. Okay, Sheetal, thank you. And Tata. So remember, क्या है? TOF, TGA, TAPVC or Tata. How to remember? If they are asking most common, it is this. If birth they are asking, go for this. Snowman plus other feature, most common with TET spell. TET. And boot house. What is the shape? Boot. Most common boot, this. If it is TGA, egg. If TA, remember tap. टैप से आया वाटर, टैप से आया वाटर, वाटर से बन गई स्नो, स्नो से बन गया स्नोमैन. So if it is like this, boot, this is egg, and this is snowman. So these are the shapes. Okay. Tata is truncus arteriosus and tricuspid atresia. Tata. Easy. So this is the summary. Okay. So if birth, TGA. If snowman, you can go for TAPVC plus. There is equal pressure in all chamber. And finally, TOF is tautology of palate. And Tata. 2E is if they are having a mother, bipolar mother. Mother is bipolar. She has a history of lithium. Then we will go for Epstein. And Epstein B for box. B. So what is bipolar Epstein box? B. So if there is bipolar history, then box and this is called as your what condition? That is your Epstein anomaly. Okay. And what is Eisenmenger's? It is VSD with reversal. With reversal of shunt. Now it become right to left. So it become right to left. Okay. So thank you very much to Jeetu Meena, Doctor in White. Okay, for yes your compliment. Okay, I'm just doing my level best to simplify the question so they don't have to worry in the exam. Pediatrics is taught by your Pankaj Tikku sir and other faculties very well. Okay, right now the focus is to make it so easy and effective that when you revise, you don't have to face problem. If they are having Acyanotic, remember da. ASD, VSD, PDA. ASD, VSD, PDA. But if they are having Cyanotic, remember it is ta. 5 T's and 2 E. How do you remember? I told you, if there's any history of bipolar, Epstein, box, it is Epstein anomaly. If there is boot-shaped heart or since birth, Cyanotic spell, it is tough. What is the treatment of tough? Treatment of, tell me treatment. Yes, management is squatting on knee chest, and drug is we give vasoconstrictor, phenylephrine, beta blocker, morphine, or what is the surgery? Blalock or yes, POTS. POT or Blalock. So POT and Blalock is this, okay? So that is very, very important in this case. So what does POT and Blalock do? POT and Blalock is basically, we are trying to create an alternate connection so that the oxygen can reach into the arterial system, okay? Thank you, Dr. Shavani, Dr. Neha, okay? Yes. I hope this will help you solve questions in the exam. So that will cover our cardiology. I've covered each and everything. Now let's do milestone. I will make it easy for you to remember the milestone. Use my technique. You will never ever make a mistake. So remember, fine is basically hand movement. Gross is basically leg, back and neck. So I'll start with social and language first. So let's start. So let's see with language. So write like me 1, 3, 6, 9, 12, 24, 48. So you can write like me 1, 3, 6, 1, 3, 6, 9, 12, 24, 48. And they're all months. Okay. Okay, I'll do extra topics later. Abhi, let me go in my flow and let me finish. Okay, Nandini? Let me finish all these things. Okay. So 1, 3, 6, 9, 12, 24, 48. So first say 1, 3, 6, 9, 12, 24, 48. So remember, first the child will do vocalization. Vocalize. Vocalize. Wo, wo, wo. 1. 3 is coo, 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 cooing. Cuckoo. Then 6 is mono syllables. Then bisyllables. 12 is 2 to 3 words. Like is 12th month, his birthday. So happy birthday. Happy birthday. So child can say happy birthday. 2, 3 words. So when can he say happy birthday? Then at 2 year, 24 months means 2 year. He can make a line or story. So he can make a sentence. So when can he make a sentence? Sentence. So sentence is 24 months. So sentence is which month? 24 month. And 48 is 4 year. 4 year. है ना? एक था राजा, एक थी रानी, उनके 2 बच्चे, फिर राजा रानी मर गए, खत्म कहानी. So it is story. So story is 4. So story is 4. So very simple. 1 is vocalize. 1 is vocalize. Vocalize. Ek. Then 3 is cooing. 6 is mono. Ma, ba, ma. Then dada, baba is 9. Then 2, 3 words is 1 to 2 year or 1 year. And 24 is sentence. Sentence is what? 1 line. And 1 line is between 2 points. That is 24 months. And story is 48. That's the simplest summary you can remember. Let's revise. Okay. I'll ask you, you tell me. Write like me. 1, 3, 6, 1, 3, 6, 9, 12, 24. So 1, 3, 6, 9, 12, 24 and 48. So what is the story? So what is 1? 1 is vocalize. 3 is what? 3, 3. So 1 is vocalize. 3 is, yes, it is coo. This is mono. This is bi. This is 2, 3 words. This is sentence. Then 48 is story. So these are the case. Yes, very good, Nandini. So remember, vocalize, coo, mono, bi, 2, 3 word, sentence, story. So first, vocalize, cooing, mono, bi, 2, 3 word, sentence and story are the concepts. So sentence and story. Sentence and story. Clear? Now we will discuss. Okay. So now we have a look at what concept. We will see the fine motor. So write like me. So you will not make mistake. 4, 5, 6, 7, 8, 9, 12. M. Month. So 4 month, 5, 6, 7, 8, 9, 12. 4, 5, 6, 7, 8, 9, 12. Follow my method. 4. Remember 4, the child is not having ability to use single hand properly. So he move both the hand by dexterous approach. So it is bidextrous. Bidextrous approach. MCQ. And now he can move things. So at 5 he transfer them. and then monodextrous. Monodextrous approach. So I'll make it easy for you. So at 4, both the hands, okay. Then at 5 he move. So at 5 we move 5, okay. Then at 6 single hand. So monodextrous. So bi, transfer, mono. फिर से easy. Bidextrous is 4, transfer is 5, and what is the mono? Mono is 6. Now he can use even the fingers. So now what happens? He is using the hand here. Now he'll be using the fingers. So he can hold the object with the lower fingers or upper. If holding with lower, it's called as ulnar grasp. Then he can like this. So this is ulnar grasp. This is the ulnar grasp. This is the radial. He's using upper finger. So that is, musician of ulnar. So this is the ulnar. So it is ulnar. Yes, 6 months is both. Mono. Very good. Mnemonic Neha. So 6 is monosyllable. 6 is monodextrous. Then 8 is radial grasp. Radial. And once he is able to use the upper, he can even use the 2 finger. So 2 finger will come after the 8. That is pincer. Pincer grasp. But initially it's not very mature, not very strong. He keep losing. Like example, he can use, but object will keep falling and is not able to hold properly. That is called as immature pincer. Immature. But at 12 it become mature. He can hold it like a proper person. I can lift. This is mature. This is mature. This is mature. Can you see? Chutki. Yeah. So ये 9 बन गया ना? 9. So this look like 9 shape. So 9. So it is looking like 9 shape. Can you see? So what is the pincer look like? 9 shape. So when does the pincer appear? I hope it looks straight. It is 9. So 9 is immature pincer. 12 is mature. Can you see? So 12 is mature. So what is the shape? 9 is the shape. Can you see? 9. I know my fingers don't look that nice. So it is 9 shape. So what is the 9 shape? It is your pincer. Okay. Now after the pincer, he start grasping the object. So now what happens? Now there is holes. You can say pen and spoon. So he now hold objects. Hold object. What object? 15, 18. 15, 18. Okay, 15, 18. At 15, it is cup without spill. And at 18, it is what? At 18, it is what? Spoon without spill. So when does he hold the cup and don't spill it? It is 15. Spoon is 18. Spoon is 18. And special thing, at 18, he can also scribble. He can scribble. So when does he scribble? It is 18. Okay. Now comes years. Now he can, yes, use pen. Pen. So 2 year, 3 year, 4 year, 5 year, 6 year. So 2 year, 3 year, 4 year, 5 year and 6 year. Okay. It is 6 year. Okay. So are you clear? Now understand. 2 year is line. And line is between 2 points. Between 2 points. Remember, line is between 2 points. Same way 2 year. Then 3 year he is circle. And circle is round. So circle is 3. So circle is 3 round. 4 is square and cross. And you all know they have 4 sides. So what is 4 side? Square and circle. Square and cross. Circle is round. So remember, circle has 3 parts. It has the center, then it has a radius, diameter and circumference. So 3 parts. And circle is always you make 3. And 5 year is triangle. That's the biggest misconception. People think triangle come, no, triangle is complex. So it come after 4 year. So triangle is 5 year and it is hexagon. Hexagon. So hexagon is what age? It is 6 year. So are you clear? So hexagon is 6 year. Are you clear? So this is the summary. Okay. So I hope you'll remember. I made it easy for you. So I hope I can get, okay. So all those who are still with me, watching with me, Thank you very much, and I assure you, you will not forget them now. Okay, so I simplified. So remember, there is hand, dexterous approach, then finger, then hold, then pen. Okay, clear? Yeah, obviously cylinder and rhombus is very good. 7 Neha, you are right. 7 pe rhombus, rhomboidal shape, and cylinder is at 9. Okay, I'm not writing because sufficient. Very important question I'll tell you. So let's start. What is 4, 5, 6? By transfer mono. Say with me. What is 4, 5, 6? Say with me. What is 4, 5, and 6? Let's revise. Okay. What is 4, 5, 6? 4 is mono. This is transfer. 6 is by. So mono transfer. Then what is 7, 8, 9? 7 is ulnar. 8 is radial. This is pincer. This is pincer. What pincer? Immature. And 12 is mature. So 4, 5, 6. It is mono transfer by. Mono transfer by. What is 7, 8, 9? It is ulnar radial pincer. Ulnar radial pincer. Pincer is immature, then mature. Okay. It is mature. Okay. Then come our 15, 18. 15 and 18 are cup and spoon. Cup and spoon. Then come 2, 3, 4, 5, 6. 2 is line. 3 is circle. 4 is square. 5 is triangle, and 6 is hexagon. 7 is obviously rhomboidal and heptagons, and 9 is cylinder. Okay, yeah, it is bi trans mono. Yes, you are right, bi trans. Very good. अच्छा मैंने गलती कर दी. Sorry, really sorry. Okay, होता है भाई, होता है, जल्दी जल्दी में होता है. You are right. So 4 is bi, 5 is transfer, 6 is mono. That's why I prefer taking live classes. It's difficult for me to take recorded lectures or non-interactive classes. Okay, very good. Okay, now one more interesting thing. When does the handedness, right or left, develop? So remember, right or left handedness. This is a PYQ. So it start at 15 months and fully develop at 3. So that's why by 3 years you can make an idea the child is right or left handed. So when do you know he is a right or left handed? It is 3 years. It is 3 years. So when does the handedness, right or left, start? It is 15. And when does it develop? 3 years it is fully developed. So 3 years it is fully developed or seen. Okay, all clear? Now we'll discuss the gross. So in gross you already know some, like neck holding, etc. So 3 months is neck. Okay, so 3 is we are taking neck holding. Okay, how कर लिया मैंने जिंदर, I just corrected that value. Okay, so neck is 3. Now what I'll discuss, right like me. Okay, neck holding. So neck holding. Okay, now what I'll tell you is very, very important. Please pay attention and learn with me. Okay, so right like me, sit, stand, walk. First is with support and then without support. So let's start. Remember, mnemonic is 68. So that's why if tripod they are saying 5 months. Okay, but if they are saying with support, it is 6, without is 8. Mnemonic is 68. 68 sound like sit. Remember, 68 sit. 6, 8 sit. Then stand is 9 and 12. How to remember? 9 to 12 a.m. 9 to 12 we are standing in the OPD. So we doctors stand in OPD. So remember, morning 9 to 12 we stand in the OPD. Okay, 9 to 12. Okay, we are standing in the OPD. Okay, are you clear? And walk. When do we walk? We walk after lunchtime. So 13 to 15. So 13 to 15. Okay, so that is around 13, 13, 14, 15. 13, 14, 15. तो क्या करते हैं? चलना चालू. So चलना, चला, 14. 13, 14, 15, चला. 13, 14, 15, चला. So sit mnemonic is 68. Stand is 9 to 12. Walk is 13, 15. So remember, when are you sitting? 68. Sit, 6, 8. Sit, 6, 8 is 68. Stand is 9 to 12. You stand in the OPD. And what is walk? 13 to 15 is walk. Okay, walking. 13, 14, 15. 14 means chala, chala. I can speak in Hindi also bit. So 14 is chalna, chalna. Okay. Now, what age a child or girl can run away from the family but will not be persecuted? 18 years. So remember, 18 month. So they're all months. So what month you run? Obviously, you run at 18 month. So 18 month run from the house. No charge of what? Abduction or kidnapping. Kidnapping is not, but mainly abduction. 18. Then jump is 2 year. Then tricycle is 3 year. Also stairs. 2-year-old can climb the stairs. Then tricycle. Tricycle. What is tricycle? Tricycle is 3 year. 3G. And 4 year is steer, alternate, and also skip the rope. Skip rope, walk backward, and climb the stair. So that is the case. Okay. So let's revise them with me. So what is sit? Sit mnemonic is 68. So what is the sit mnemonic? 68. 6 with support. Some books say 5 also, but you can take 6. Okay. Then what is without support? 8 month. Then walk. How do you stand in OPD? 9 to 12. You are standing in the OPD. And what is walk? 13, 14, 15. And when you can run away? 18. Jump 2 year and also climb the stair. Tricycle 3 year. 4 years skip the rope plus climb the stairs. Alternative step. Alternate step. Just like adults climb stairs. Okay. So they ask you just stairs. It is around 2 years. If they say stair with 1 by So we'll start again. Okay, just 1 minute. Okay, we'll start. I'm discussing social. So we'll start again. Okay, just give me a minute. We'll start. Join in. Join in, please. Join in. Yes, I also have health pay. Please join in. Okay, we are starting social milestones. 1 minute. Okay. Let's start. अरे आगे. No break. I just was checking some issue. No, it was actually just a temporary blip. So let's continue. Okay. So I was discussing about the social milestones. It's not YouTube, it's my side. Okay. What happened from my side? it got stuck. So we are discussing the social milestones. Okay, now in social, just remember, like me, right, like me. Yeah, I came back. Okay, please join in. Okay, because we just need half an hour. The point is, I said it is 3 to 4. There always be some discrepancy. Okay, like I say it is 13, some book have given 12 year also. So this is something which is always controversial. Okay, so what I am giving you is a version as per Tikku sir and Gai. If any issue, you can take whatever value you remember. Okay, so I'm giving you what is given as per the book. Okay, if you want, I can show the reference also, that handedness develops the establish. So it's given 3 to 4 year. Okay, so it's given 3 to 4 year by the age of 3. See, so by the age of 3, so it's given 3 year, plus I also got it from most of the book between 2 to 3. Okay, clear? So 2 to 3 years, so it is 3 years. Okay, so 3 year is a best answer. Okay, 3 years. Clear? Clarity, obviously it's well defined, is 4 to 6 year, but 3 year is the age where it is observed or seen. 3 years. So I think it's 3 years. Okay. Babulal, actually, bhai, I keep studying all the time. In COVID time, I was studying almost all the important subjects, and I prepare notes for all important subjects, and I want everyone to be benefited from these sessions. That's why I'm working hard to help everyone pass and clear the exams. Okay, and main thing is I'm not just mugged up or summarize. I'm trying to actually make concepts in all important subject, all the diseases, because my subject is physiology, and physiology is the core of each and everything. If you know physiology, you know normal. If I know normal of everything, I can just convert it to pathology, pharma, medicine, pediatrics very easily. Just rule is physiology. Okay. Okay, let's start. So in social, write like me, 1.5 month, 3 month, 6 month. So 1.5 month, 3 month, and 6 month. Okay. Now all three are smile. All three are smile. Now you can also write it what, 6 to 8 weeks. Now it is social smile. Social smile. Then 6 month is mother. Recognize. Please, please, please don't take stress right now. Just remember, exam is there. You study and give the exam. Do your best. Okay. Like as a surgeon, what do? You try to save the limb. If not, let's remove the limb, save the life. And if can't save life, at least make it pain. So as we doctors, we have to look for what we can do. Salvage. The word is salvage. What you can salvage, what you can save. If 1 month left, let's study for that. 10 months left, so we'll always make efforts and attempt. Okay, so mother, recognize. So now he smiled at mother and recognize. So that is called as what? The social milestone. Okay. So thank you, Ankit bhai. I'm trying my level best so that I can help each and every student in their respective way. And I promise 100 plus MCQ. So if you check the content at the end, you will get 100 plus MCQs from our content, and 100 plus MCQs are enough to give you a good rank. Because if you can get 100 questions, no one can stop your good rank from coming. Okay, so that's my target is get a very, very, very good rank. Okay, 3 month is your yes. What thing? What? It is smile at mirror. That is recognize itself. Smile at mirror. That is now he recognize self. Are you clear? So that is the whole summary. So 1.5 month is social smile, 3 month is mother smile, and 6 month is smile at mirror. Okay, fine. Now let's come back. Now we see the next concept, that is 7 month. Okay, yeah, I'll write like this. So first is 7 month, and what is double of 7? 14, 15. So we remember 14 or 15th month. So remember, these two are anxieties. So एक आती है 7, एक आती है 14, 7 और 14. Remember 7th day of the week, 7th day is Sunday. So Sunday who come? Stranger come to house, guest. And that child is afraid. So Sunday is 7th day and is having guest, 7th month. So he get afraid and that is called stranger anxiety. Okay, और ना 7 समुंदर पार, 7. So कौन आया 7 समुंदर पार? अंग्रेज, Britishers, and they captured us. Stranger anxiety. And 14, 15. Remember 14 week is Valentine Day. So Valentine Day 14 you meet with your partner, 15 break up. So separation anxiety. So 14 और फिर 15 separation, जुदाई. So क्या हो गया? Separation हो गया. So 15th is separation, so separation anxiety. 14 को Valentine बनाया, 15 को breakup हो गया. Separation anxiety. या you are afraid कि your partner will leave you after Valentine week. So that is why it is separation anxiety. Are you clear? So separation anxiety. So let's revise once again. 7th is stranger anxiety Sunday, and 14, 15. 15 is what? Tata, bye bye. So after Valentine week, there's the separation anxiety. Okay, separation anxiety. Okay. So remember 14 or 15. 14 is Valentine, 15 is separation. You'll never forget this mnemonic now. Okay. Now write down 9, 10th month. 9th is what? Baby comes out. So 9 month baby comes out and say tata bye bye uterus. So it is tata bye bye. Wave bye bye. Wave bye bye. So when does the baby, the child say bye bye? 9th, 10th month. Bye bye. Okay. Okay. And remember, yes. What is the next? It is 10 to 12. It is peekaboo. So play peekaboo. So child will keep hiding peekaboo, peekaboo. So that is around, yes, 10th, 11th month. So 9 is, you can say 9 month is wave bye bye. 10 to 11 or 12 is your peekaboo. So remember 9, bye bye. 9 month is bye bye. 9 month is bye bye. Yes, start khatam bye bye. And 10 to 12 is peekaboo. 10 to 12 is peekaboo. Okay. Now comes years. Years. We'll discuss years. I'll mainly go to the main years, 3 years. 3 years. So remember 3. There are 3 colors: red, green, blue. There are 3 names. First person, I, me, myself. I, you, they or them. He or her. So I, you and they. 3 person. I, first person, second, third. And there are 3 genders. Even when you're filling the NEET PG form, it asks 3 gender: male, female, and also Supreme Court has given permission to 3rd gender, that is transgender. So that's why we are having 3 gender, 3 name, 3 color. So 3 year a child can tell you color, name and gender. So that is why gender is established at 3 year. That's why he can now identify whether it's a boy or girl. Boy or girl. So that's why yesterday I told you in psychiatry what age the child develop the gender identity. It is 3 year and have Oedipal or Electra complex. So Oedipal, Electra complex. Oedipal or Electra complex. They appear at 3 years, called as the phallic phase of the psychosexual development. So what phase? Phallic. Okay. So I hope it's clear now. So it is 3 color, 3 name. Now 4 year. 4 year is bowel control. See, bowel has bowel, well, 4. So bowel is 4, bowel. Urine take more time. So 5 year is bladder control. That's why if a child is doing nocturnal enuresis, we don't punish till the age of 5 years. So what is the bladder control? 5 year is the bladder control. So that is why nocturnal enuresis is more than 5 years. Another treatment. First is toilet training and hygiene. Then we will do the bed alarm method. India already has a bed alarm method. I'll tell you. Bed alarm method is mainly for foreign country where the child sleep on the bed, and once the child start passing, the alarm wins. It's type of negative conditioning and the child wake up. India already. Why? The parents sleep with the child. So parents sleep Indian style. So Indian bed alarm. So the moment the child pass urine, the parents who are sleeping next to, so the papa, mama, and the child. So they are sleeping on the bed. Indian style now. See, we all slept with our parents. Okay, so no need to be shy. We all were sleeping. So what we are, again, middle class people, we have single. I don't know, maybe some rich people are watching the lecture, but I tell you, we were poor, so we used to sleep on one bed. Okay, even brother, sister, they used to sleep. Okay, later, some will sleep on floor also. Okay, so now as the child start wetting the bed, the parents no is wetting. Parents wake up and but फिर गीला कर दिया तूने, उठ 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 हरामजादे उठ, and they wake up the child. So that is Indian bed alarm method. Child passes urine, parents wake up and they will, yes, stop this. Okay, so Indian bed alarm method. यार मैंने सारी PDF डाली है. Okay, I can show you. See, these are the PDF I have already made. So if anyone is still not having the PDF, they can inform me. Pediatrics, physio, psychiatry. Okay, so I will give the PDF to you people in my own way. Okay, so Indian bed alarm method is very, very important. Okay, and if still not working, then we can go for nasal desmopressin. So it is desmopressin. So it is desmopressin in this case. Are you clear? हाँ बिल्कुल. हे राम, ये क्या कर दिया, छी छी छी, है ना. So are you clear? So desmopressin is the case. Okay, or we can use imipramine also. Imipramine. But what is better? This is drug of choice compared to imipramine. Okay, MCQ. So I hope it's clear. So I hope you are enjoying the class and you are also learning with me, because we are maintaining a very good speed. We have covered almost 60 or rather 70% of pediatrics. We have done what? Cardio disease, we have done jaundice, we have done diarrheal diseases, there's dehydration, we have done milestone. Very fast we are going. Okay, let's move on. Okay, so we've done this. Okay, toilet training, bedlam, fine motor we have done. Okay, now gross we have done, jump, skipping road. Now let's come back to nephrology. So nephrology, first, if they are mentioning nephrotic syndrome, there's a proteinuria, cloudy urine is there, edema is there, so edema, facial edema, and if infection or clotting factor disorder is also there. Most common treatment is minimal change disease. It's minimal change. If fail, so we will give steroid, prednisolone. And if fail, then we give azathioprine, or we can give what? We can give cyclosporin, or we can give what drugs? Tacrolimus. So we are giving immunosuppressants. Okay, immunosuppressants. Cyclosporin also can be given. Okay, so azathioprine, cyclosporin can be given. Cyclophosphamide can also be given. They are steroid resistant. Cyclophosphamide. Phosphomide. Okay, then if there is less proteinuria, less than 3.5 gram per day, and there is hematuria, Coca-Cola urine, the moment they say, plus there is hypertension also, and hypertension. This is your nephritic syndrome. So this is what condition? Nephritic syndrome is there. So it is nephritic. Yeah. So minimal change, there is no finding under microscope. That's why I call it minimal change disease. Okay. Treatment is steroids. Now, most common is post-streptococcal glomerulonephritis, history of sore throat, group A, streptococcus, ASO titers decrease complement. Treatment is steroid. We can give antibiotics. Okay. And urine, tuck, yellow is alkaptonuria. Mousy order is phenylketonuria. So remember, Alka is a girl with dark long hair, or you can say Alka reverses Kala. See, remember, Alka. If you reverse, it becomes Kala. So dark urine is alkaptonuria, and all these inborn errors of metabolism, they are recessive. So they are all are autosomal recessive. One more interesting. All this alkaptonuria, phenylketonuria, homocystinuria are autosomal recessive. Okay, and treatment ACE also. Add ACE inhibitors also, ACI or ARB. And if again not responding to steroid, we again give your, yes, immunosuppressants. So clear now? Fine. Now nervous system. In seizure disorder, there is an increased electrical discharge from the cortical neurons if motor feature is called as conversion. Okay, so muscle contract and relax multiple times, that is called as your, so muscle contract is called as what? It is called as the tonic phase. This is tonic phase. Contract, relax multiple times is called as clonic phase. So this is what a GTCS is all about. In GTCS, there are two periods. One is the muscles contract like this. This is called the tonic phase. And when they start contracting, relaxing, that is called as the clonic phase. So what is clonic? It is contract and relax. So contract and relax multiple times. Okay. And if more than 2 episodes of seizure, it is epilepsy. Now, most common in neonate is subtle seizure. It is because of incomplete myelination, and it is this hypoxic, ischemic encephalopathy. Okay, like example, you just write. Okay, so just remove this part, it is not needed. Example, hypoxic ischemic encephalopathy. So example, yeah, like hypoxic ischemic encephalopathy. Okay, now infantile spasm. Here the muscles go in contraction and remain contracted, that is flexor, extensor and mix. So flexor is jackknife, extensor and India is mix. India में सब कुछ mix है भाई. Now what are the findings? Sudden symmetrical tonic contraction of the muscle. EG show hyperrhythmia. So hyperrhythmia, no pattern, high voltage activity. And what is the drug of choice? It is ACTH or steroids. So that is infant. Age is 6 months to 1 year. The most common age is for infantile spasm. Okay, yes. Then we have the febrile seizure. There is an association with fever. Age is 6 months to 60, that is 5 years. So the age group 6 months to 60 months, that is 5 years. Okay, fine. That is febrile seizure. Now febrile seizure are mostly, they are generalized GTCS. So it's a GTCS. After fever, it's a GTCS. Now it is after 24 hours. If duration is 5 to 15 and 1 episode, it's a simple. If more than 15 minutes and more than 1 episode, it is called as the, yes, complex febrile seizure. It's not complete, it's a complex one. Let me correct it. It's complex febrile seizure. Complex febrile seizure. Okay. Complex. Okay. Complex febrile seizure. Next is for the treatment. Treatment is we will give intranasal midazolam or IV lorazepam. So we can give lorazepam to the kid or rectal diazepam. Now as per some faculties which I heard, they say diazepam is better. So I will not go in any controversy from my side. I will just give an advice. You can go for lorazepam. It is very effective, very fast, or we can go for rectal diazepam. Prophylaxis is clobazam. So what is the drug of choice? Lorazepam. And what is for prophylaxis? Clobazam. Then absence seizure is mostly school going children. There is no motor feature in simple one. If it is a complex, we have no loss of consciousness. No loss. This blank spells staring. Teacher complained the student is not paying attention. Okay. And in EEG we see 3 hertz spike and wave pattern. There is 3 waveform in the 1 second. Or the treatment, this is now modified. I will change it. What I have got from the latest update, that it is nowadays ethosuximide, because earlier India ethosuximide was not available. Now it is available in India also. So that's why ethosuximide is the overall drug of choice. MCQ. So who is the drug of choice? It is ethosuximide. Okay, is the drug of choice. And if they ask you where is valproate, valproate is after, if not available, then valproate. And valproate spelling is wrong. Valproate is preferred in which condition? Valproate, it is preferred in complex with motor features. So what is valproate? It is basically for if motor symptoms, we will prefer valproate, called as atypical absent seizure. Then we will go for, yes, valproate. Otherwise, ethosuximide is the oral drug of choice. Okay. Yeah, I'll do PSM also. Don't worry. I'll do other subjects also. Don't worry about that. Okay. Clear? He will join. Don't worry. Very soon we'll be having combined session. Okay. Chalo. Absent seizure. So are you clear? So it is loss of consciousness and it is also called as Patet mal. Okay. Now we'll see neural tube defect. Neural tube defect very commonly seen in a mother taking valproate. So most sensitive for that is alpha fetoprotein, but most specific is choline esterase level. Prevention is folic acid 4 mg per day or 4000 microgram a day. Now spina bifida. It is basically can be open or closed. Closed is called as occulta. Here in spina bifida, what happens? The vertebra are not fused. So that's why you can see a defect. And this effect causes a protrusion in which the skin is covered. There is a tuft of the hair. Here tuft. But there is multiple type. Like example, in case there is meninges present, it is called as meningocele. If meninges plus neural tube, then it's called as meningomyelocele, or myelomeningocele. So this is myelomeningocele. You can see the nerve fiber, yellow ones. So yellow ones are the fibers, and here only meninges are protruding. This is occulta where the hair is there, and there's a swelling at the lower end of the back. Okay. Yeah, I'll share the file. Okay. Now cerebral palsy. So what is the funda about the cerebral palsy? It's a damage to the brain in the early life. Mostly it's hypoxic, ischemic encephalopathy. Prematurity is the most common cause. Can be by torch infection, meningitis. Most common type in India is spastic. There's no treatment. Only you can say rehabilitation or physiotherapy is the solution. There's no treatment. Okay. Brain tumor, mostly it is secondaries, metastasis, and primary are glioma like astrocytomas. Okay. Now if it is supratentorial, astrocytoma. If it is infratentorial, then it is medulloblastoma in the children, which is midline tumor, MCQ. So overall cerebral astrocytoma, in children medulloblastoma is there. So it is medulloblastoma. So I'll just show you a photo of medulloblastoma. So let's see. So this is our spina bifida. This is our supra and infra. So this tumor is medulloblastoma. It's a infratentorial. Can you see that? So it is infratentorial. Okay. And this is the concept. Are you clear? So medulloblastoma. It's a children with these are ventricles, medulloblastoma. Okay. Now this is our fontanelle. In fontanelle, remember the anterior, and this is our posterior. Okay. And let's just do it. So in this case, remember aage piche. So anterior close much earlier. Anterior close at the age of 6 to 24 months. Okay. So when do the anterior close? So anterior will close at 6 to 24 months. So when do they close? 6 to 24 months. Posterior is 2 to 4 months. What is posterior? 2 to 4 months. Okay. Now we discuss the respiratory diseases. Now if there's an intrathoracic obstruction like wheezing is there, and mainly expiration. Example, bronchiolitis, asthma. COPD is obviously not, but can be congenital one, like congenital emphysema. I can write. Congenital emphysema. Okay. Now, bronchiolitis is called as the first wheezing of infant 1 to 6 months. Most common cause is respiratory syncytial virus, RSV, and treatment is what? It is ribavirin. Okay, ribavirin. Then, if it's an extra thoracic obstruction, stridor is there, mostly in the inspiration. and they are above sternal notch. So where is extrathoracic? It is above sternal notch. Okay. And if supraglottic, it is inspiratory stridor. If subglottic, it is biphasic stridor. It is biphasic stridor. Are you clear? Then what is croup? Croup is laryngotracheobronchitis. Steeple sign is there. Steeple sign. So I'll show you steeple sign. This is the steeple sign. So this is steeple, teeple. LTB is steeple. Can you see this steeple sign? So this is the steeple sign. Okay. Then if there is laryngomalacia, remember omalacia, omega, omalacia, omega. So this is the omega sign, omalacia, omega sign. Okay. And TB turban, TB turban, TB turban, TB is turban, TB is turban. Okay. Are you clear? So remember, above glottis is inspiratory, subglottis is biphasic. Okay, glottic can be expiratory or can be biphasic. Okay. Okay, Richa? Yes, omega shape. Okay. Next is, what is here? And remember, subglottis is mostly expiratory. Subglottic is mostly expiratory. Glottic is the one which is mainly biphasic. Okay, it's right slightly this. So are you clear? Now we'll discuss neonatology. I'll give something very interesting. I'll write it there. Understand a mnemonic: fetal length. Copy here. Fetal length. Fetal length and age. Remember. So first is, remember, 1 month square formula. Square. So 1 month is 1 centimeter. 2 month is 2 to the power 2. It is 4 centimeter. Then 3 month is 9 centimeter. 3 to the power 2. 4 month is 16 centimeter. And 5 month is 25. So that is how you calculate the height. Okay. Now what happens is after that we need to multiply by 5. So now 6 month into 5 is 30 centimeter. Then 6 month into 6, 36 centimeter. Sorry. Then I think I made a mistake. No, it should be 6 month with 5, 7 with 5. Sorry. 7 month into 5 is 35. Really sorry. Then 8 month into 5 is 40 centimeter. And 9 month into 5 is 45. So now what is the age at the birth? 50. Almost 10 months. So 50 centimeter. So this can be a potential exam question. I have given you formula. So till 5 month we square, then we multiply with 5. So that's why 1 month fetus, it's not fetus right now. So 1 month is 1 centimeter. Okay. After 9 weeks, we start calling it fetus. So 1 month is 1 centimeter. 2 month age is 4. 3 is 9. 4 is 16. 5 is 25. 6 into 5 is 30. 7 into 5 is 35. 8 into 5 is 40. And 9 into 5 is 45. So what is the 9 month fetus? It is 45. And at birth, what is into 5? 10 into 5, 50. Now you will never make a mistake. 10 into 5, 50. So what is the length? Is 50. So what is the birth length? It is 50 centimeter. And at 4 year, it become 100 century. So 4 साल में चौका मार के century. So याद करना, birth पे 50, double in 4 year. Double in 2 to the power 4, 4 year. 75 is 1 year and 90 is your 2 year. And 4 year is 100 centimeter. Okay. Chalo. So I hope you are benefited by my teaching. Okay. Clear? All my knowledge I am trying to deliver to you in a very effective manner. To our entire pediatrics is, really great. If I was you, I would have been very happy to gather these notes and revise them 2-3 times so that I can solve a large number of questions. Obviously, Doing classes are important. If you do the regular class, you learn much better. After class, just going through this PDF will solve a large number of questions. We are just to the last 2 pages. We'll finish in another 15-20 minutes. Not even 15, just 10 minutes. Okay. So birth weight, what is the normal birth weight? Normal birth weight is 2.8 to 3 kg. So low birth weight will be 2.5. So less than 2.5 is low birth weight. 1.5 will be severe and 1 is very serious. So remember 2.5 to 1.51. Very easy. 2.5 to 1.51. 2.5 is low birth weight. Then less than 2 is, again, it is moderate low birth weight. 1.5 is severe and 1 is very severe. Okay. Now head circumference normally is 35. More than 2 increase is hydrocephalus. At 1 year it is chest more than head. So that is chest is more than head. Before that head is more. Before that head is more than chest. Okay. First urine is 48, but some book gave 24 also. So I'll just take it. And stool again 12, 24, but up to 48. But if more than 48, then we investigate whether it is yes normal or abnormal. Can be yes obstruction or maybe some kind of like Hirschsprung disease. And what is the color of meconium? Meconium is black green color feces. So black color feces. So meconium is the first feces. It is a black color. Okay, it is the black color. Okay, yeah, Shana is a good example. So someone who can teach in the end. Okay. So newborn has no sweating and no shivering, and they are covered with this vernosa, okay, and they have heat genesis by non-shivering thermogenesis, which is lipolysis of brown fat via beta 3 receptor using uncoupler protein 1. So what is the protein? Uncoupler, also called as ubiquitin. Okay. Now brown fat is present in the head, nape, shoulder, etc., but absent in adult. Now what is the mechanism of heat loss? So remember, maximum heat loss at birth is by evaporation of the amniotic fluid which is being evaporated. And if they ask later on, so maximum 70% by radiation, infrared, and that is via head. And then 30% is convection and conduction. Convection is wind, convection, wind. And radiation is direct, and conduction is via contact. So conduction, direct contact. So remember, radiation is rays, infrared, red. I'll change the color. So it is infrared. So radiation is infrared, convection is wind, conduction is direct. Now maximum loss is via head. That's why head is being covered. So need to cover the head. Okay. Yeah. Now comes the question, what is the temperature of the nursery or NICU, that is neonatal ICU? It is 25 to 28. If they have to choose one, go with 25. Clear? We can go with 25. Hyperthermia is more than 37.5. Then mild hypothermia, also called as cold stress, is 1 below the hyper, that is less than 3.65. Okay. Then if 32 to 36 is moderate, severe is less than, and between the two is moderate. Moderate is 32 to 36. So 32 to 36 is moderate, and mild is less than 3.65. Okay. And I think I should remove it. Okay. So that is severe. Severe is, and the best temperature, rectal. Now what do you give for the preterm babies and low birth weight? Kangaroo mother care, KMC. So this is KMC, kangaroo mother care, KMC. And we can also use incubator for low temperature. Now let's see KMC, kangaroo mother care. So skin to skin contact, baby lie attached to the belly of the mother, and it is used for prematurity less than 37 and also low birth weight less than. And what is the goal? Goal is early breastfeeding. Now understand, preterm babies have poor sucking action, so that's why we use Katori or Palladi feed, that is less than 37 or 36. So if less than 36 sucking action is poor, we can use Katori or Palladi feed. If can't swallow, that is less than 32 weeks, then we will use nasogastric tube. So remember, if there is very young child, can't even swallow, then we will use nasogastric tube for the feeding. If it is 32, 36 and sucking action is there, but then we will use this. So swallowing not there, we give nasogastric. Sucking is poor, we give Katori or Pallidi feed. So that is the summary. So I'll again just show you. This is kangaroo mother care. So this is the kangaroo mother care that you can see. Okay. So Katori or Pallidi feed. Katori or Pallidi feed. Okay. When do you give Katori? Preterm less than 37. And when do you give nasogastric? Books have given 32, 28 to 32. So 32. Okay. Yeah. Less than 28, we give IV. So it's very good. Okay. So less than 28, Ankit, is IV fluids. Less than 28 weeks. So are you clear? So 36, 32, 28. Now neonatal reflexes, rooting and sucking. Okay. So we know rooting is sucking is basically baby searching for the breast. So that is called as the rooting and sucking. And they are normal till the age of 1 year. And then they disappear. So up to 4 months, they will not be seen. So 1 month, they are normal, then they disappear. Okay, disappear. Now come our what reflexes? The Moros. Moro is basically Shah Rukh Khan. So remember Shah Rukh Khan is, तो जैसे बच्चे का छोड़ा सर, ऐसे हाथ आगे आते हैं. So this extension abduction of arm is called as a Moro's reflex. So appear 28 to 32 and disappear 3 to 6 months. If more than 6 months it persists, if it persists, that is pathological. So that is pathological, maybe indicating some cerebral palsy or delayed developmental, milestones. So when does it appear? 28 and disappear. I have a very good video for this. Let's show. So actually I prepared properly for all the sessions for you people so that you can benefit maximally. So this is our Moro. See, so they are holding the baby is appear 28 to 32 and disappear by 3 to 6. Can you see? So this movement of hand is called as baby is actually startled. So this is called as Moro's reflex. This is the Moro's reflex. Can you see? ऋतिक रोशन भाई क्या होंगे वैसे करता है टाइटनिंग में से हाथ बढ़ाता है कौन शाहरुख खान सो लाइक शाहरुख खान एक्सटेंडिंग द आर्म मोरो क्या हो रहा है और दो मोरो ओके देन कम पैराशूट अपीयर आफ्टर बर्थ एमसीक्यू एक चीज पहले टोनिक नेक रहेगी व्हाट इज टोनिक नेक व्हेन यू टर्न द नेक सो नेक टर्निंग कॉज व्हाट नेक टर्निंग कॉज same side limb flexion like if you turn the neck this side the limb will flex this side if you turn this side the turn so this is called as the tonic neck reflex so when you turn the head this neck the hand will also turn this is called as the tonic reflexes are you clear appear 35 disappear 5 months so let's revise when does Moro appear 28 to 32 disappear is 3 to 6 and when is tonic neck they appear at 35 but disappear at the 5 month. Now parachute appear after birth. MCQ 6 to 9 and disappear no it persists disappear never it persists all life so it persists all life so what reflex will persist all life that is parachute let me show that also so this is parachute at different age so it's a baby girl very cute okay you will be very happy to see so have a look okay so now he's bringing the baby down so like a parachute see no response so there is no parachute response okay I'll give a summary so this girl 10 now she bring the hand so that is parachute okay so earlier she trusted father she was not having any problem and now she's becoming old the baby girl is old अब इसको father में भरोसा नहीं गिरा देगा साला so that's why she is moving the arm forward okay that is extension of arm तो क्या कर रही है extend कर रही है क्या बोल रही है क्या कर रहा है गिरा रहा है मेरे को पापा हैं पापा मुझे गिराएंगे so that's why remember one line summary before 9 okay it doesn't appear so that baby trusts the father and doesn't do any response कि पापा हैं सही लेके जाएंगे after 9 she doubt कि पापा गिरा रहे हैं मेरे को टक्कर मारेंगे they will make me collide with the floor and damage my body so she move the limb forward so याद करना पापा ने आगे yes asymmetrical is obviously one side is not able to move so that is Moro's very good Ankit that's true okay chalo let's see the last points that is first is Apgar score so Apgar score is 0 to 10 and we do it what time 5 1 to 5 minutes after birth. Okay, so for the timing 1 and 5 minutes. Less than 3 severe, we need to do CPR and resuscitation. A, B, C. What is A? Airway, we need to clear by suction, or maybe we need to intubate. B is breathing with ambu bag. This is our ambu bag which we use for ventilation. And remember, if there is CDH, congenital diaphragmatic hernia, or upper airway obstruction, bag and mask is contraindicated. Okay, and CDH is asked multiple times. This was asked in the exam, so I'll just give you a congenital diaphragmatic hernia. It's a very important question, and please see the photo. We'll see all the gut intestine pushed to one side. This is asked multiple times in the exam. You can see the intestine in the thorax. This is your congenital diaphragmatic. So intestine herniate through diaphragm into the thorax, and you can see this bowel loops, this diagram. So this diagram can be asked in the exam. This is congenital diaphragmatic hernia. Okay, so clear now? Yeah, this is a very important question. Okay, so here we don't do bag and mask. And C, circulation. C is circulation, so which I'll discuss. So the circulation, if there is heart rate less than 60 beat per minute, 60, then we do chest compression. Either we can use a 2-thumb method or 2-finger method. So either 2 thumbs or 2. Ratio is 3:1. That is, in 1 minute we have to give 90 compression and 30 this. So I'll just discuss. 3 is chest compression, and 1 is ventilation. So the ratio 3:1, 3:1, and the target is 90-30 ratio. That is 90 compressions and 30 ventilation. And also we can give adrenaline. We can also give adrenaline. Okay, so can give adrenaline. So you can give adrenaline. Okay, done. Now Apgar score you already know, so it's not something which I need to discuss, but it's very fast. So in Apgar is appearance. Now if the color is blue, that is cyanosis, we give 0 point. If center is pink but periphery is blue, that is indicating some peripheral cyanosis, maybe heart disease, that is 1. If baby is pink, everything pink, is your yes, 2 point. So it is 2. Okay, next question, pulse. No pulse is 0, less than 100 is 1 point, and over 100 is 2 point. Okay, then grimace, that is reflex irritability. So now whatever, the baby is floppy, doesn't respond, is like completely, muscle tone is decreased. Then minimum response, very little response, is 1 point. And if the baby cry and move, that is called as the yes. So make facial expression, that is called as grimace. Activity is muscle tone, no activity, then flex body, and actively moving is 2. So flexor is 1, moving the body is 2. And respiration, no respiration, 0, slow irregular 1, vigorous cry is indicating 2. Now we'll discuss the last disease, then we'll wrap up. Last disease is our hyaline membrane disease, also called as RDS, respiratory distress syndrome. It is due to defect in the surfactant. Surfactant is made by type 2 pneumocytes and Clara cell, and it contains lecithin, that is DPPC. This I covered in physiology class. And SPB, which is surfactant protein B. Surfactant protein B. So what is SBP? It is surfactant protein number B. SPB, surfactant protein B. And what is the ratio? We have to check the lecithin sphingomyelin ratio. What is the normal ratio? It is more than 2. More than 2. If less than 1.5, there is a risk, and 1 is severe risk. So what is the ratio? Normal is more than 2. And if it is less than 1.5, risk is there of RDS. And less than 1, severe risk. Okay. Severe risk. Okay. Now, preterm babies have less surfactant, so that cause increased surface tension, which collapse the alveoli, that is called as atelectasis, and also it will pull fluid into the lung, and this fluid, pulmonary fluid, and the fibrin create the hyaline membrane. So they create hyaline. That's why also called as hyaline membrane disease. So that causes difficult breathing, distress is there. What are the marking? Respiratory rate become more than 60, which also increase in pneumonia. Also there is, for severity we use what? Silverman Anderson scoring. There is a audible grunting sound, nasal flaring, retractions or recession, and there is seesaw upper chest movement, and also there is retractions or recession in xiphoid or subcostal margins. Let me show you. So this is Silverman Anderson. So what are the findings? So I'll just put, so this is the Silverman Anderson score. Okay, so full screen is not available. Okay, so this child, you can see retraction upper chest, you can see seesaw movement, clear. Also there is nasal flaring and grunting sound is there. So these are the findings. So audible grunt, nasal flare, seesaw chest movement, and also there is xiphoid recessions, okay, and lower chest retractions is 1. So total score is 8. More the score, more the severity. Are you clear? So that is Silverman Anderson score. Okay, now what is the X-ray? Obviously there is a hyaline membrane, so we'll see the ground glass, which is also seen in COVID-19 appearance. So COVID-19, again we will see the ground glass appearance. Okay, now what is the treatment? CPAP is the treatment, or we need to give artificial surfactant via nebulization. We can give steroid also for lung maturation, and also humidified oxygen. But remember, what is all again? Remember 80 to 85. Don't increase more than 85, else it can cause drop. That's retinopathy of prematurity. So we need to keep it low. Now we'll discuss the growth. Last topic, just 5 minutes. Okay. So first is growth. WHO growth chart we use, which is weight for age. So they ask you WHO growth chart contain what? It contain weight for age. And normal is mean plus minus 2 SD. If you are within 2 SD, that's fine. If you are out of that range, that means there is a malnutrition, malnourishment, which is causing the stunting of the grace. So stunting is short stature, wasting is low weight. Okay. So first is, what is stunting? Stature. So it is height for age. MCQ, stunting we take height for age less than 2 SD. If severe, less than 3 SD. Severe is less than 3 SD. Same way, what is wasting? Weight for height. They're all exam question. WHO, weight for age. Stunting, weight or height. It is height for age, and wasting is low weight for height. Low weight for height, that is your WFH, weight for height. Less than 2 SD is wasting, severe is 3. Now diagnosis of this, wasting, we use Shakir tape. So this is Shakir's tape, which is given here. So Shakir's tape, we all know Shakir's tape. So Shakir tape, mainly it is for malnutrition. We use mid-arm circumference is measured here. And what is the values? So let's see. So in the case of Shakir tube, we see first question. It is 13.5 is normal, less than 12.5 is mild, and if 11.5 it is severe. Now what are the criteria of acute severe malnutrition? If it is acute, 3 criteria: bilateral pitting edema, that is indicating loss of protein or low protein, mid-arm circumference less than 11.5, and weight for height. Remember, it is not weight for age, it is weight for height less than 3 SD. So please remember, what are the 3 criteria of acute malnutrition? What are the 3 criteria? Yes, less than 11.5 Shakir tape, less than 3 SD. Which thing? Weight for height. It is not weight for age. See, it is weight for height, not weight for age. And the last criteria, last is bilateral pitting edema. Bilateral pitting edema. And what is the treatment? We need to, yes, admit the patient and give proper nutrition. So we need to. Last is PM, that is protein energy malnutrition. I will just give one thing. In this case, I will open this and do it from my file and just wrap it up. So the last topic. Okay. See, I've covered lots of topic in this case. So this is the last topic I'll be covering. So first is in marasmus. In marasmus, there is mainly what? Protein, calorie. What is calorie is the main problem. but both are deficit. In kwashiorkor, edema is the primary problem. Why? Because there is a lack of protein. Lack of protein causes what? Lack of protein causes what? Lack of protein causes edema. Why? Oncotic pressure will decrease, so that causes shifting of fluid from vessel to the interstitium, edema. Plus also this moon face, upper limb wasted, okay, but wasting is more in the marasmus. So marasmus can look and can show pot belly, but I'm removing the pot belly because not the hallmark. Hallmark is severe wasting. Which child is very hungry? Yes, obviously who's very hungry? Very hungry is marasmus, mara mara bacha. Who is not interested in eating? So not hungry or showing apathy. Then infants 1 year old show marasmus more, and this age child develop fat, this food fads, can avoid I will not eat, kya bana rahi ho. So that's why 5 year. Then weight is very low, 60%, here 60 to 80%. Then there's a flag sign. What is flag sign? Alternate bands. So flag sign is alternate bands are there, which I've shown here. Bands. So white and black bands, that is called as the flag sign. Also the skin show flaky paint dermatosis. So that's why it shows the skin to peel off like the paint falling from the walls. Okay. And obviously infections are more here because of lack of antibody. Finally, good prognosis for marasmus, bad for kwashiorkor. So this is kwashiorkor. Okay. So this is the two child, marasmus and kwashiorkor. So marasmus and kwashiorkor. So I think this is more than sufficient. So I've covered all the important topic. Okay. Yeah. So this is the finding we will discuss or see. Okay. Fine. Okay. Yeah. Shaki's tape. Okay. Chalo. So as you were saying, okay. So basically in case of the coarctation of aorta, as you all know, what is going to happen? As the aorta get narrow, it will be very similar to aortic stenosis. So one simple rule, it is very similar to aortic stenosis. So what happens? There will be very high pressure till the coarctation, plus it will cause hypertrophy of the heart, mainly concentric hypertrophy. Okay. After the BP will be lower, and you see a figure of 3. And what I am going to say is it is already prepared when I'll be discussing what? Our medicine. So already I have prepared all these things for my medicine session. That's why I'm not going to take coarctation of aorta right now much more. So I'll be just passing it on. Where is this? So I've already done every preparation for this. So aortic stenosis, this is a medicine notes. Okay. So this AR, this AR, all the signs of AR. This is our AS. So that's why I will be discussing it, all the changes. So I'll be discussing all these changes in medicine. So don't worry. Okay, you can just relax. So we will be discussing it there. Okay. Yeah, obviously I discussed now. Age. So remember, if marasmus is 1 year, 1 year, 2 year, and more than 1 year can have this क्या कहते हैं, नखरे करता है बच्चा, क्या है, बड़ा सेलेक्टिव, क्या बोलते हैं वर्ड, इज वेरी फजी ईटर. आई विल नॉट ईट दिस, मैं नहीं खाऊंगा. सो दे अवॉइड ईटिंग प्रोटीन्स. Okay, and they just want to eat sugars. So that's why they are not lacking in energy, but they are lacking in protein. So lack of protein, edema, is swelling, is mainly kwashiorkor, oshiorkor. So mnemonic I made was oshiorkor, edema, kwashiorkor, edema, edema. In marasmus, mara mara, muscle wasting, ma. So remember my mnemonics: kwashiorkor, oshkor, edema. And in marasmus, muscle is wasted. So that is the case. Are you clear? Chalo. So I will wrap it up the session. Other topic will do. Okay. So yeah, we have to do surgery also, PSM also, vaccines. I'll be doing my level best. So you have realized by now कि I am trying my level best to come Gautam Nagar. You are most welcome. I'll be taking the session there. Okay. So tomorrow is class, and after that I'll take the FMT tomorrow. So let's meet tomorrow. Okay. Thank you very much. Clear? So yeah, I'm trying my level best to do everything. Okay. So I'll be saving this file. I know it's a very precious file even for me. I worked very hard to create this file. Even I will be afraid if it is lost. Okay. So now it is safe. See, I did a pharma class also. this is my pharma class, this is my physio. I've taken multiple subjects, more than 14 subjects I have taught till now, and they are all there. So I have updated the file. Let me just check it. Is it updated? Yeah, it's updated. So this is the updated file that we are having. I'll be sending it to you. Okay, so just wait for some time, it will be updated to you. Okay, chalo, thank you. Tomorrow I think 6 p.m. Okay, thank you Dr. Shravani, Dr. Vidyapati, okay, Jitu Meena bhai, Sandeep, okay, thank you very much. Yeah, we work very hard, you all know. Day and night we are just doing one work, that is help you people get very good score and marks in the exam. Chalo, thank you very much. चलो, थैंक यू वेरी मच. थैंक यू वीरन, रॉकी भाई. अभी PDF में दे दूंगा भाई. आई विल गिव टू भाटिया पीपल, यू कैन टेक फ्रॉम देयर. ओके, एंड यस, विल एंड अप विद दैट क्यूट बच्चा. ओके, दैट बेबी इज वेरी वेरी क्यूट. आई विल ओपन दैट. यू कैन सी दैट बेबी. आपको पता है किसकी, ये वाली की बात नहीं कर रहा, ये इमेजेस की बात कर रहा हूँ, ये वाली. So I'll end the session with her. Okay, so okay Jitu, क्या बात है भाई. Thank you very much for taking the class. Yeah, I'll update the file. Okay, don't worry. Thank you Dr. Gautam, Neha, Viran, okay, Prashad, Vasi, Shushma, Nilanshu, Sparsh, Bindu Reddy, Mimin, Ankit, Gautam, Shravani. ओके, थैंक यू टू ऑल. संदीप, कोई रह गया तो भाई सॉरी, नाम नहीं लिया तो. क्या धोनी. जी तो कह रहा है भाई, अगर 8 ईयर हो गए दैट मीन्स आई मस्ट बी अंकल, सुपर अंकल. या मेडिसिन आई विल टेक. ओके, मेडिसिन इज द सब्जेक्ट आई विल बी फोकसिंग मेनली 2 days. फॉर मेडिसिन आई हैव केप्ट 2 days बिकॉज आई नीड मोर टाइम टू कवर मेडिसिन टॉपिक्स. ओके, रोरी को 16, थैंक यू वेरी मच फॉर ज्वाइनिंग. ओके, धोनी, गुना. Medicine I think is end of Feb. Yeah, chalo, I think we'll wrap it up. Thank you very much to everyone who's there and watching. Take care, bye bye. Thank you Ajit bhai, KV Ajit. Ruriko 1616. Okay, it's a very Japanese looking name, so we have students from very unusual names. Okay, chalo, take care. Okay, hope to see you people soon. Okay, Valentine week, I hope you're all enjoying. Chalo, so let's start. Chalo, should I wrap up? Yeah, I'll eat. FMT 6 p.m. Dhoni medicine end of Feb. Okay, chalo, bye bye Dr. Lydia. Take care, bye bye. I'll wrap up. Okay, मैं भी थक गया हूँ. I'm taking class since morning. Okay, so morning I started taking class for offline, online, daily batches. Then now, so it work almost 13-14 hours.